Any questions? Everybody okay?
Oh,
Some etiology that you see with Alzheimer's is, of course, dementia. There are many forms of dementia, by the way, but Alzheimer's is not something that you can diagnose for sure even until they're dead, believe it or not. But usually they will follow a certain pattern. There's atrophy of the frontal and temporal lobes. 6% of people have it greater than 60, 20% greater than 80, and the genetic factors actually are less than 3% of cases, because people who deal with parents that have Alzheimer's are very fearful that they're going to develop it. So they look for things like that. So it's really not very common in families per se. Possible changes in the chromosome 21, which is the same as Down syndrome. Both of them have deposits of amyloid in the brain, and that happens in a Down syndrome child all through its life. But this happens in an Alzheimer's patient later on as they actually just do the autopsy on them. That's what they find. They have a lot of neuronal loss found throughout the brain. Diagnosis is only officially at the autopsy. Clinical diagnosis is what they see. So they see progressive dementia, and then they start watching for behavior patterns. And so the other thing that you have to do, though, is you need to rule out other causes for dementia. So they're going to do CAT scans. Sometimes they'll do an MRI, and the brain will have shrunk down a little bit. So sometimes you see atrophy of the brain. You'll see that on a diagnosis occasionally. But you do need to rule out any other causes. There are 10 warning signs of Alzheimer's. And so recent memory loss that affects job performance. So people will possibly forget things often and may repeat the same question, forgetting the earlier answer. By the way, as you read through these, you're going to find that when you're tired, you do some of this.
how does your brain atrophy?
What they do is they go in, it just kind of shrinks down. I don't know if it's a fluid thing. I don't know if it's because there's less neurons. I don't know. But they'll have atrophy on the, that's a good question. We need to ask somebody that has more knowledge than that. So they do repeat sometimes the same question, and you see this with dementia too, where people are just starting to have dementia, which may turn into Alzheimer's. 2, they have difficulty performing familiar tasks. The person may make a meal and then forget to serve it, forgetting even that he or she made it. They have problems following, directions. They have trouble doing those kind of things. Problems with simple language, forgetting simple words or using them inappropriately. I have a friend that's doing this, and this is my biggest concern for him, is that I'm not, his language difficulty. Disorientation. This is the biggest one that actually starts making you look at Alzheimer's, where maybe they have to place them in an Alzheimer's center, is if they happen to get out of the house and they get lost, they don't even know where they're at. So that's a biggie. Decreased judgment, sometimes forgetting that he or she is responsible for a child's care. That would be very important if they were a child caregiver. And so that is something that they forget. And abstract thinking difficulties, for example, forgetting what numbers are for when balancing a checkbook. They lose their mathematical abilities. 7, misplacing things such as putting an iron in the freezer. Y'all never done that before, have you? Y'all don't know what an iron is. Do any of y'all know what an iron is? Oh, y'all do? Oh, good. My children don't know what an iron is. So, changes in mood or behavior, getting angry easily and crying often, and that's probably what you see a lot. They get angry quickly. And then 9 is personality changes, becoming irritable, suspicious, and fearful. And probably suspicious is the biggest one that I see that's a real problem, because they think everybody's out to steal their money. And so, here's a caregiver, and you just have to be really careful. Because I'm going to tell y'all, there's a lot of people out there that steal from old people. And I'm going to tell you that some of them are their family members. So always remember to listen to people, but again, when you're dealing with dementia, they think everybody's stealing from them anyway. So it's kind of a hard thing. I always keep an open mind to that, but listen to it. A lot of old people people steal from them. Common. So just be aware of that. And then 10, loss of initiative, not wanting to get involved in activities he or she previously enjoyed. They always want to stay home. They don't want to go. It's a sad thing to see them deteriorate like that. Usually there's a kind of clinical features and progression through 3 stages. It usually takes 3 to 10 years to go through the stages of Alzheimer's disease. Some of them seem to live a long time. Stage 1, forgetfulness. 2, failing attention. 3, declining math abilities. 4, decreased ability to make simple decisions. That you take them out to eat and they can't tell you what they want. They can't make a decision about their food. What they want to wear that day, to wear that day, put clothes on. 2 is where you start seeing the personality changes, speech problems, loss of memory, irritability, and severe anxiety and depression. This friend of mine, I told his wife, he's been watching the news since the election. So he is like this. And I said, get him off that TV. That is not a good thing for him to do. It's not good. Have y'all felt that too when you watch news all day? That it kind of makes you, it's not a healthy thing for us to do. So anyway, he is very anxious and he's very depressed. And then stage 3, I would say this man I'm talking about is in stage 2. Stage 3 is where they really get more bedridden, non-ambulatory. They have decreased ADL abilities, and then you start seeing incontinence. When you start seeing incontinence with Alzheimer's, then that's usually kind of the end stages, by the way, unless they had issues before. Some women leak anyway, but if they didn't have issues before and they're starting to go into that, that's actually kind of the final stage 3s. Any questions on that?
And like the late stages, do you think that they're still coherently there?
No, I don't. I think the family suffers a lot, but I don't think they're there at all. And they don't recognize people, and I don't know. And we don't know where that stops, so it's hard to know how often you need to go visit or care for them, or, and then someday they'll have a day where they're completely there. and then you don't want to miss that day. So, it's kind of hard. It's a hard thing. Usually we see Alzheimer's in long-term care facilities, and we normally see them for a second diagnosis. They've fallen and broken a hip. They have done something like that. If you're doing exercises with them, of course, they need to be short and simple and the same thing every day. So kind of this is one that you don't need to increase a lot, and you're not going to see them very long. If you're seeing them for general debility, you're just going to get them up going, and then and if you're working in a nursing home, you're going to turn them over to restorative so that they can keep doing some maintenance therapy with them. But usually, again, it's for a secondary diagnosis. You do want to keep them ambulatory as long as possible, but you realize that this lengthens their life. Some of these people walk 10 to 12 miles a day. And if you go into an Alzheimer's unit, they have a path where they'll just walk it. One of the things, years ago, when they started taking restraints out of nursing homes, when I first got out of PT school, we were restraining all of our old people. It was crazy. And the worst thing that they do with these Alzheimer's patients is they would put them in a jerry chair. Do y'all know what a jerry chair is? So it's a chair where they can't get out of. So they bring them back and lay them into a reclining position like a recliner. And so the people, they can't push anything, they can't do anything, they just have to stay there. So they don't have any choices to do that. You don't see jerry chairs tremendously, unless someone is very disabled, but they're careful about who they allow to do that. So when you go into a nursing home, you're going to look at restraints, because restraints used to be a big problem. And so when I decided to do some nursing home work, that's been about 30 years ago, they're out of a nursing home, they had like 89 clients, 52 of them were restrained. And it had just come out that we were going to get rid of restraints in nursing homes. And so immediately they wanted to get rid of all their jerry chairs. And so we had 5 Alzheimer's patients that we got out of Jerry chairs and got them where they could walk again, because spending a lot of time in Jerry chair, they were getting weak, they couldn't do anything. And so all 5 of those people were able to be ambulatory and get around and function after we got them out of Jerry chair. That was one of the most significant things I ever felt like I did, because it was just so neat to get rid of all those restraints. You know what it's like to be tied into a chair and you can't get up? That's a horrible thing. It's a horrible thing that we've done to our old people at times. And I'm not saying you don't have to have it, sometimes you do. But other times, another thing that was happening during that time is we were so, giving them so much medication to keep them from getting excited. It was overused. There are times it needs to be used, but it needs to be evaluated all the time. It needs to be something that's looked at all the time, because you don't want to keep them so down that they can't even function. So they are people in there, even if they have dementia, they're a person in there. And so just kind of keep that in mind. And mainly for the ones, if you're working in a nursing home, who don't have any family, because they're the ones who are, you know, if you have family members that check on those things, that's good. Any questions on that?
At the nursing home I worked at, they use a lot of Jerry chairs, but they also use lap buddies, which are like
Yes.
too.
Yeah, and I like those, and I think patients like them better. The thing about being tied in chairs and in bed, it used to kill people. They would wiggle out of it, and they had a posy thing that went across their chest, and those people would wiggle out of bed, and then they would choke them to death. It was crazy things that we did. And so that was always a possibility with that. Lap buddies are just pillows that fit inside the wheelchair, and so that it kind of gives them a understanding of where they're at. And I think sometimes they're kind of a security for them. You'll have some that don't want lap buddies. There's all kinds of things to do. You can put them on a cushion that is kind of has a wedge to it so that it's harder for them to get up. You can put footrest on their chairs, but then again, they have to push with their arms if you do that. So there's just all kinds of things. You do the best you can to get them where they can function and get around. And so you have to evaluate everyone, but normally physical therapy is involved in restraint removal. Okay, we don't hardly see any post-polio syndrome anymore, but the other day I saw a guy that had post-polio syndrome. And probably in the 80s and 90s, we had tons of them. What this was, the polio era ended pretty close to the early 60s, because the polio vaccine came out in 1959. And so most of your polio patients then are dead now. You know, most of them, we went through them where they were in their 70s and their 80s, and most of them were gone. So now if you see post-polio syndrome, it was in someone who didn't have their immunizations when they were kids and they got polio. So post-polio is basically a return of symptoms on a polio patient, and 20 to 30 years down the line after they had overcome that. Some of the things, and so I didn't put what all the symptoms were, but basically what happens is the muscle that was affected in polio will become very weak, and it kind of deteriorates. They think it was probably some type of overuse syndrome type thing, and so they get where they can't use those parts again. So if they were affected in both their legs, then they can't walk anymore when they've walked for years and years. And so it was really sad. They also deal with a lot of fatigue. You just do all kinds of things to help them to continue to function in society. So you have to kind of provide methods for self-management. You want to alleviate causes of pain. The areas become even more painful to them. So possibly you might look at some bracing and AFO on an ankle if they're dragging their toe, just different things like that. Decrease abnormally high workloads on muscles relative to limited capacity. So you have to teach them energy conservation, because they get where they can't function in those muscles anymore. Correct and minimize postural and gait deviation mechanically. So again, maybe bracing, posture, looking at posture with that. maintain and increase function, safety, and quality of life. So that's what you want to do for them. And sometimes that means they need to go in a wheelchair half a day if they're ambulatory, because they do not have the energy to function all day long. I have one lady who years ago, this was years ago, I used to treat many of these people, but she was ambulatory and had been. She had it when she was about 2 years old, and she still had children at home. So she had gotten where she was completely in a wheelchair and was trying to, so we went into her home and just made it wheelchair accessible because it had not ever been before. The interesting thing about polio people is they, like I was telling you with disabled people, or even children, polio, the philosophy for polio children was, nobody's going to take care of you, so you're going to have to get with it, and you're going to have to somehow find a way to work. And so they pushed these polio patients. It was unbelievable. You would see, when I was young, you would see polio patients who were quadriplegics in a wheelchair working a full-time job. It was very common. And so polio patients are they're difficult a little bit to work with because they have made it. They've overcome whatever happened to them. And they have that attitude, and so it's hard for you to recommend things to them. So you have to work with them very humbly. But again, y'all may never see them. There's just very few of them out there anymore. We just thought, this might be my last year to teach this, but literally just recently I ran into one. You want to teach them time management skills. For a patient that ambulates, I may do wheelchair for part of the day, assistive devices, just different things. And the thing about exercising them is you never go to fatigue. So you're going to do about half of what you would think you'd want to do with them. There are times that you don't want to fatigue people, so don't go in there being gung-ho. You want to look and be a little more conservative, and this is a patient that is like that. We talked about Guillain-Barré, same thing. You don't want to overwork them. So you want to establish an intensity that the patient is able to tolerate, and then you're going to cut it in half. So if they're able to do 20 long arc quads, you're only going to do 10. If they're able to do 15 sit-to-stands, then you're only going to do 7. You're going to cut it in half. This is a standard thing for your post-polios, is that you're going to establish what they can do, and then you cut it in half for their program. Never work with a patient or the muscle to fatigue. Most disabled people, especially post-polio syndrome patients, are high achievers and overdoers, so you have to deal with that. It's a psychosocial thing with that type of patient. Most post-polio patients have negative feelings about orthotics because basically when they were little, they wore those metal braces, and so they don't want a brace. They don't want that. So you have to kind of talk them into it and show them that they're much better than they used to be. They fit on the shoe. They are plastic. You don't see them like you used to be able to. So their idea of a brace is not good. Okay, myasthenia gravis. Normally you are not going to see a patient with this. You're going to, except for other things, because we can't really treat this. This is treated with medication, but I want you to understand it. It affects women greater than men treated too. Women, normally it happens in their 20s to 30s. Men, it's later on in life in their 50s to 60s. Fatigue and inability to use muscles, but mainly it's the facial expression. Their swallowing is a problem, and then sometimes it affects their breathing muscles. So that's when it kills them. Literally, it could kill them. You could be working with a patient, and that happens. So it's mainly the facial and the throat muscles. It is an autoimmune disease. Antibodies destroy acetylcholine at the myoneural junction. So what does that tell you? What is the acetylcholine? That's a neurotransmitter, and so it destroys that at the muscle and the nerve junction, and so you don't see that. You see a decrease in that. Main danger is respiratory failure. Again, they could just quit breathing. Treated with drugs to decrease normal destruction of acetylcholine. So it is usually treated with drugs, and some do well with it and some don't. It just depends. Other than weakness, neurological findings are normal, so sometimes this is very hard to diagnose because they'll test them for everything and nothing shows up. So until they check probably for their acetylcholine levels, they don't know. And then some of the treatment would be, of course, respiratory therapy. And y'all all know how to do that now, right? What would you do?
Diaphragmatic breathing.
Diaphragmatic breathing. What else would you teach them?
Personal breathing.
Personal breathing, all that good stuff. How to strengthen and all that. Energy conservation techniques, strength training programs utilizing maximum isometric contractions could be instituted in clients with mild to moderate myasthenia gravis. Normally, you're not going to treat them much, but I just wanted you to be aware of it. We had a patient in our pro bono last year who had it, but we were treating her for just more for her neck and problems there.